We're getting started now. So welcome back, everyone, and thank you for joining us again. This is day 2 of the Critical Care Boot Camp. We're very excited to welcome you. This seminar series aims to strengthen the care of critically ill patients globally. It's based on a survey with close to 800 responses from across the globe. So over the 5 days, we will be discussing stroke, traumatic brain injury, DKA, sepsis and septic shock, and acute coronary syndrome. This series is made possible through Stanford University, the University of Rwanda, Nairobi University, the Institute of, for Medical Equity and Global Health, the Critical Care Society of Kenya, and with special thanks to Stanford Center for Innovation and Global Health for seed grant funding. We're also excited to bring together a team from across the globe, including nurses, physicians, emergency medicine doctors, anesthesiologists, surgeons, and critical care specialists. Before we get started, we want to go over some housekeeping and etiquette. We want to maintain a professional and respectful webinar. So if you disagree with something, please do so politely. You can use the chat function to introduce yourself, but please reserve questions for the Q&A function. Both the chat and the question and answer buttons are on the bottom of the screen. Professional development. To obtain a certificate of attendance, please make sure that you attend the webinar for at least 45 minutes and fill out the survey at the end. And this session is being recorded, so your attendance is your consent to being recorded. All of the materials that will be presented today, including slides and resources for the bedside algorithms, will be hosted on the Learning Resource Center. You can see the QR code there that you can scan. We'll also put the link in the chat. All slides will be there for download. In consideration of our participants that are not native English speakers, please recognize that closed captioning is available on Zoom. It can be found at the bottom of your screen, and it might be helpful to use closed captioning to follow along, as our speakers will be using English. Again, certificates of participation and attendance will be sent out to any participant who attends for 45 minutes and fills out the survey at the end of the seminar. We should have these arrive by email. Make sure you put in your name and email address to which we want that sent, and they should arrive within 7 to 10 days. We have a WhatsApp group. If you'd like to join the conversation, you can scan this QR code or use the chat function, or sorry, the link here, which we will also put in the chat box for you. Today, I'm very excited to introduce our speakers. We are talking today about traumatic brain injury. And our speakers today are Dr. Sami Matar, who's a third-year resident in emergency medicine at Stanford University. Sami also has a master's in public health focused on epidemiology, and he's very interested in medicine and conflict areas, as well as resuscitation and critical care medicine. Dr. Bansi Njoki is from the University of Nairobi. She's an anesthesiology resident. Danielle Devakis is a nurse by training, but went on to do additional training to become a nurse practitioner and has specialized in anesthesia and critical care. Dr. Eugene Yoshimi is an anesthesiology consultant. He's also trained in simulation and perioperative medicine. He's currently doing an obstetrics fellowship at Western University in Ontario, but it has been trained by the University of Rwanda for his Masters of Med and Anesthesia training. And Dr. Rachel Kimani is a consultant anesthesiologist, very experienced in global health. She's associated with the University of Nairobi and Gabathi Hospital. She's also recently completed her master's in global surgery from King's College in London. So welcome to all these amazing speakers. And with that, I'm going to turn it over to Dr. Sami, who will start the slides for this lecture. Thank you very much.
Great. Good morning, everybody. I'm just working on getting this set up here. Okay. I hope that everyone can see my slides right now. Good morning, everybody. Thank you for the very generous introduction, Dr. Crawford. And I wish we could have a video to see everybody's faces here this morning. It's always hard to just be talking here into the ether, but I'm really excited to be here with all of you all. And I'm joined here with Dr. Bansi and Joki, and we're going to be going over critical care for traumatic brain injuries. It's a very broad topic, so we won't be able to cover every aspect of this very broad topic, but our hope and our goal is to be able to hit a lot of the major points here. The outline for this discussion is going to be as follows, going over just overview and definitions, some brief epidemiology, ways to classify TBI, traumatic brain injury, going over assessment and physical exams, diagnosis methods, management, and then outcomes at the very end. And with that, I'm going to hand it over to Dr. Njoki.
Hello, I'm Dr. Bansi. So I'll begin with a definition. So basically, traumatic brain injury results from an insult from the brain, an insult to the brain from mechanical forces.
Yes. All right. Yeah, and it's a very common problem. It's a leading cause of disability and neurologic dysfunction in adults. The global incidence from a study in 2019 showed that there was about 27 million new cases of traumatic brain injury and almost 49 million prevalent cases in the year of 2019. And if we were to spread it on a map, this is a map with age standardized incidence, meaning that the incidence rates are weighted for age, which helps correct for diseases such as TBI that are disproportionately affect certain population, certain age groups, such as older adults. And so countries with who have disproportionately younger populations might show lower rates of TBI. But using this method, we can standardize, and we see that it's a common problem worldwide, but some countries have higher rates of TBI than others. And some of the leading causes, the most common cause globally is falls, but there are many other causes such as motor vehicle accidents, pedestrian road injuries, conflict and terrorism, as well as a few others. And one trend to keep note of, and I'm sure that's something that we all face in our own practices, is that with increasing urbanization, we see very high rates of traumatic brain injuries from vehicle accidents, and as well as with older populations. As a population start to age, we see higher rates of traumatic brain injuries with clinical manifestations.
So we can classify traumatic brain injury into two distinct periods. So there's the primary period and the secondary brain injury. So the primary is basically the initial mechanical forces that will result in shearing and compression of your vascular tissue and your neuronal tissue. And then your secondary is basically the consequences of further physiological insults. And this is where you want to act on to prevent further injury to your patient. So in the primary, you can have, this is where you'll see your hematoma, hemorrhagic contusions, diffuse axonal injury as well. And in the secondary, you'll have secondary insults like hypoxemia, hyperglycemia, hypercapnia or hypocapnia, electrolyte imbalances, mostly hyponatremia, seizures and infection. So you want to prevent your secondary insults to prevent deterioration of your patient. So this is basically a chart that analyzes your main causes of your secondary insults. I divide them into systemic secondary insults versus the intracranial ones. So like hypoxemia, it can be caused by hypoventilation, anemia, when the patient is bleeding out too much. Hypertension would be caused by hypovolemia or sepsis as well, the commonest one. You'll have hypercarbia or hypocarbia caused by either hyperventilation or respiratory depression. Your hyperthermia mostly will be caused by the hypermetabolic state you see in traumatic brain injury, while also your hyperglycemia will result from the same. So some of these, you will be able to identify the cause and intervene appropriately. So we can also classify traumatic brain injury depending on the mechanism of the injury. So you can have penetrating traumatic brain injury, non-penetrating, these are your blunt traumas, or an explosive blast. So this will also help in ranking your differential and knowing how to intervene specifically for each patient.
So I think here's just a good time maybe to interject with a poll. We have some questions I want to ask the group before we go through the rest of the slides, so that way we can have a kind of before and after assessment.
So learners, try to answer the questions. There's 4 questions in the poll. The first question is, when treating a traumatic brain injury patient, what 3 H's should be avoided? Hyperventilation, hypoxia, hypotension, heartburn, heart rate, or hemorrhage, hyperventilation, hypoxia, and hypertension. The second question is true, false. Hyperventilation, which results in end-tidal CO2 less than 35, causes vasoconstriction, which can decrease perfusion to the brain. True or false? The third question, again, true or false, emergency medical service providers can take actions to help prevent secondary brain injury in the pre-hospital setting. True or false? And number 4, a patient with traumatic brain injury should have an oxygen saturation above what percent? 95%, 80%, 85%, and 90%. We'll give you just a few minutes to answer these questions before we resume the presentation. Okay, we'll stop the poll here and revisit the answers at the end of the session. Thank you.
And hopefully we can we'll have answers to all those questions by the end. We'll continue here.
You will move on to assessment. So when you're assessing the traumatic brain injury patient, it basically follows the same guidelines when you're assessing a trauma patient. So you have your primary survey and your secondary survey. So primary survey looks at airway, breathing, circulation, disability, and exposure. So first of all, at airway, you check, while doing the primary survey, sometimes you can skip the order and start with circulation. So you assess what will kill the patient first, you assess and intervene at the same time. So for airway, you check your airway is patent. Any airway injuries, is there any blockage that you need to remove? And if there's any concern, you address it at that point. Next, we look at breathing. So you assess whether the patient is breathing on their own. Can they be able to speak or vocalize? You also do your respiratory exam here. You check if you have your lung sounds, whether your chest is symmetrical, whether there are any injuries to the chest wall penetrating, how the patient is breathing, basically whether they have increased work of breathing. The parameters that you can look at is your respiratory rate and also your oxygen saturations. Then you intervene as needed. For circulation, you assess if there's any bleeding, whether you have your pulses present, your central pulses and the extremity pulses. You can check your vitals, your heart rate, your blood pressure, and you also assess for any compartment syndrome as well here. You can check if all the compartments are soft, also using the fast scan as well at this point. So at any point you need to intervene, you should do it without waiting to move to the next stage. So for disability, here commonly use your GCS score, which we'll talk more about, to assess the patient's mental status. You also assess whether the patients need a cervical collar or there are other any spine precautions you need to take. You can also check the patient's temperature at this point. So your vitals mostly will be the temperature and also pain assessment. Then you also, the last will be exposure. You make sure the patient is completely exposed and examined so that you don't miss any injury at this point. So for the secondary survey, after the primary, you'll be able to pick out any suspected injuries. And then at this point is where you decide on any further diagnostic procedures that need to be done. If a patient has a pneumothorax, do you need to put a chest tube? Does the patient need to go to theater immediately? Do you need to put like a pelvic binder if they have pelvic fractures as well? So this is a point you decide on the next plan of care for the patient.
May I ask one question? When you're doing the primary survey in the ABCDE, actually two questions. When you are evaluating the airway, do you also look at C-spine precautions?
Yes.
That's a very good question. You would, it depends on the mechanism generally, but usually by default, you'd maintain these spine precautions.
And then at what, I know you're going to talk about GCS, but when you do, is it possible to also talk about when intubation and airway protection is necessary?
Yes, absolutely.
Yes, we'll get into that. So while looking at the brain injured patient, there are specific aspects you clinically assess for. So for physical symptoms, most of the time they can present with headache, convulsions or seizures. Some might report having blood vision or double vision. On your examination, you might see unequal pupils and sometimes also fluid draining from their ears or nose. The patient might be vomiting or feeling nauseated as well. Sometimes they present with new neurological problems. Maybe they had an injury a week ago, then come back reporting, or a relative reporting slurred speech, or the patient having weak legs or arms or the face, or loss of balance as well. So these are some of the physical symptoms you look out for that will point to a brain injury. In the pediatric patient, the assessment might be a little different since they may not be able to vocalize what they're feeling or their symptoms. So the guardian might report changes in nursing habits or eating. The child might be crying inconsolably and unable to pay attention. They might show lack of interest in their usual activities, like playing with their favorite toys. There may be reports of change in their sleep pattern, also reports of seizures and loss of development, loss of their developmental milestones or regression in their milestones. There might also be reports of vomiting or loss of balance or unsteady walking. So these can point to a brain injured child. So these are some of the other cognitive and behavioral symptoms a patient with traumatic brain injury can present with. Like initially said, there's a change in mental status. There can be decreased level of consciousness, change in sleeping patterns as well, and issues with memory. They might have problems remembering, concentrating, or making any decision, and confusion or disorientation as well.
This is a very helpful kind of guideline because a lot of times we're stuck trying to decide whether or not we want to get further imaging for our pediatric populations, and we want to spare them the radiation when it's unnecessary. But this is a great kind of guideline when you should or should not get CT imaging. And so for pediatric populations for age under 2 years old, if they have a pediatric GCS under 15, if they have any palpable obvious skull fractures, or if they have altered mental status, those would all be in the setting of trauma. A traumatic brain injury would be indications to get a CT because they're at higher risk with approximately 4.4% risk of a finding on imaging for a traumatic brain injury. If the answer is no to those 3 questions, they don't have GCS less than 15, palpable skull fracture, or altered mental status, then you would ask to see if there's any scalp hematoma. You do an exam. If there was any loss of consciousness involved, if there was a severe mechanism, which would be a fall from greater than 3 feet, a motor vehicle accident with ejection or fatality involved, a bike pedestrian accident without a helmet, or being struck by a high impact vehicle, those would all be severe mechanisms. If there's enough concern, if the answer is no to all those questions, then a CT would not be indicated, and that patient's very low risk, under 0.02%. And so the recommendation would be to not get CT imaging. Then there's this middle group of people where maybe they have a more severe mechanism. They fell from a bed, let's say over 3 feet, but they're not having altered mental status or anything else that's severely concerning. Then you would have a discussion with the family, and depends on the setting and your access to imaging as well. But then you would have shared decision making on whether or not you should pursue CT imaging. And there's a similar guideline here for pediatric patients who are over 2 years old. And the risk kind of changes a little bit in this population, very slightly. And since they're over 2 years old, your physical exam changes a little bit, but essentially it's a very similar kind of algorithm. Right. And so for this next part here, so we're continuing on. So initially went over some things you might get from your physical exam. Things that you can ask about are changes in mental status. So that'd be part of your physical exam to see if they have any altered mental status. You assess if they've had any change in level of consciousness. So if they're hard to awaken, for example, they're very somnolent, unable to open their eyes, you'd assess for any confusion or disorientation, and see if there's any changes in their personality, which sometimes might be hard to get without collateral. But the thing we really wanted to focus on was this change in mental status, especially since sometimes it can be a little bit hard to assess. But we have a great way of trying to quantify this in a way that, in a language that is shared across medicine, and that's great for documentation and decision making. And that's the Glasgow Coma Scale. The Glasgow Coma Scale is, I think, something that's we're all familiar with. It's often used in contexts that it was not initially intended for. It was intended for traumatic brain injuries and assessment of mental status in that context. So this is a very appropriate place to use GCS. And it has 3 different components: eye-opening, verbal, and motor. And essentially the question is, for eye-opening, can they open their eyes? Do they open their eyes spontaneous like we're all doing now? Can they open their eyes if you ask them to open their eyes, but they're otherwise closing them? Can they open their eyes only when you stimulate them with pain, or do they not open at all? Verbal, is also more self-explanatory here. You know, are they oriented to self? Do they know their name, place? Do they know where they're at, where they came from? And time, do they know the day of the week or the year that they're in or the month that they're in? If they're confused, they get a score of 4. If they respond with inappropriate words, then it's a 3. If you can't understand what they're saying, they're just mumbling, for example, or saying something incomprehensible, it's a 2, and no response would be a 1. And then for motor, you know, do they obey all commands? Can they, you know, squeeze their hand, lift their leg, blink their eyes, whatever it is? If they're unable to follow commands, can they at least localize the pain? Let's say, you know, you squeeze their thumb. Are they able to pull away and push your hand away? Do they withdraw to pain? So are they not able to specifically focus on the point of stimulus where you're providing pain? But do they just generally withdraw their body away? That would be a 4. Or do they have decorticate or decerebrate posturing? That would be a 3 or 2 respectively. And no movement would be a 1. For infants, it could be a little bit different. Obviously for verbal would be verbal and obeying commands would be the hardest thing for infants. So for infants, the verbal organization would be, you know, do they babble? Or that would be a 5. Are they irritable? Do they just cry, but they're unable to, you know, have any kind of interaction? That would be a 4. Do they just cry to pain, but they're otherwise more somnolent and not really crying, not responding how you'd expect the baby to respond? That would be a 3. Do they just moan without being able to cry? That would be a 2. And no response would be a 1 for infants. And we mentioned decorticate and decerebrate posturing. Here's an image that kind of depicts typical decorticate and decerebrate posturing. Decorticate posturing typically involves injury to the supratentorium, and so it's usually an injury to the cerebrospinal tract at the level of the red nucleus or above, whereas decerebrate posturing is typically a lower injury down in the cerebellum or brainstem and is infratentorial. And so that can kind of help guide your differential and what you expect to see on imaging. The GCS, the Glasgow Coma Scale, is out of 15 with a minimum of 3. And so 3 would be completely comatose, unresponsive. It would be the same exam you'd have from someone who is dead, whereas 15 is the maximum score. And it's categorized, you know, this categorization might differ from institution to institution, but probably the most common way to categorize this would be as mild, moderate to severe. Mild being a score of 13 to 15, moderate 9 to 12, and severe 3 to 8. And it's really in that severe category that is considered comatose. So a patient with a GCS of 3 to 8 would be considered comatose. And that is where you would consider intubation for airway protection. There's a high risk that these patients stop breathing spontaneously, or they don't protect their airway and they obstruct their airway. And so, or they, you know, they aspirate their own vomit or their own saliva. And so they're very, very high risk for airway compromise, even if they don't have airway compromise at the time of exam. So generally speaking, a GCS score of 8 or less would intubation would be recommended.
Just to add on,
you know,
thank you.
Yeah, go for it.
Just to add on onto something about the GCS score, why it is important to have this GCS score and knowing what the GCS score interprets to is because most of these patients that you'll get with traumatic brain injury will present with like 90% have loss of consciousness. So out of this, you want to identify at what level they are so that you can now decide, should you be in a facility that does not have escalated care, you cannot be able to escalate the care in that facility, you're able to now have an informed decision of what is the next level of care and where should you have the level of care. So you're trying to understand what supportive care do you need for these patients, because at what GCS score will you be able to intubate or refer the patient and intervene accordingly. Can proceed, Sami.
Perfect. Yeah. And just another note here, most cases who present with TBI have mild TBI. Over 90% of cases in one study done in the Lancet. It was a study that was primarily focused in European centers. They showed that over 90% of cases with TBI had mild TBI, but that even half of those cases never recovered to their full function prior to the insult. And so even mild TBI can still have lasting impacts on many patients.
So this is just a table to summarize what Sami has mentioned about the outcome. So we can see, depending on the severity of the TBI, the outcome will vary. We can see for severe, you get a high percentage of dead or vegetative state, while patients who present with mild TBI have good recovery, like at 45%. This was outcome like after 1 year, at 1 year after patients had their injuries. So those who had mild TBI had good recovery, about 45% of them. While you can see in the severe cases, the high majority of them were in the dead or vegetative state. So I think this is just to highlight the impact of TBI it has to patients, even after treatment.
So there's obviously many kinds of traumatic, yeah.
We do have one good question from the participants that I was hoping maybe we could answer. And the question is, can you use GCS with children under 2, or how would you adapt the GCS score, or are there other scores that you would use for smaller children?
Yeah, let me go back here. GCS score, you can use it in children. You would just modify the exam. Obviously, they wouldn't be responsive to your commands, but there is a modified version for infants. I don't know if there's any other scoring systems. I don't know if anybody else on here is familiar with other scoring systems specifically for infants, but I know that in our pediatric ED, we still use a modified Alaska GCS score for traumatic injuries in patients for infants.
In the pediatric, the modification comes in the verbal aspect. So you grade their cries. So if the patient they can follow an object, they coo, they babble, that's like they're oriented. So if they're confused, they can be irritable, but they cry, but you can console them. If they cry to pain or are inconsolable, now you grade it as inappropriate words, that's a 3. If they moan to pain, that's a 2, incomprehensible sound. And if there are no response, it's still at 1. So the modification comes mainly on the verbal aspect.
Does that answer the question?
Yes, it does. Thank you. Yeah, that's great.
Yeah, perfect. All right, and so this is a little bit of a review from what we went over yesterday, so we'll be brief, but there's a lot of different kinds of traumatic brain injuries that a patient can experience. We went over a list of them. Diffuse axonal injury, brain contusions, and one that we wanted to focus on was intracranial hemorrhage in the traumatic setting, just because that has it probably is the most pertinent in terms of being able to intervene and manage in a critical care setting. And as we went over yesterday in the excellent stroke lecture, there's 5 different main types of intracranial hemorrhage. There's epidural, subdural, subarachnoid, intraparenchymal, and intraventricular. This is a wonderful diagram that highlights these different bleeds in a schematic way, all in one brain. And what you would see on imaging would be something like this for the different kinds of bleeds. Feel free to screenshot. We won't spend too much time here since this is review from yesterday. Here's a more complete table that goes over most common mechanisms and findings. So I'll just allow you to screenshot that if you're interested in this, but we will breeze through this. And the reason that intracranial hemorrhage is very important and why it's different than bleeding in other parts of the body is because the brain is essentially a fixed space. And so going back to the very basics, back to physics and chemistry that we learned way back when, this comes down to essentially Boyle's law, in which case, with change in a volume in one container can lead to a change in pressure, or vice versa. And so if we imagine the brain as a fixed container, we know that it has to house CSF, blood, and the brain. And it's generally in a 10, 10, and 80% proportion. And the benefits of that is that if you do develop another space-occupying lesion or mass, in this case, we're worried about hemorrhage, but it could also be a similar situation with tumors, for example. That mass, the blood in this case, would start taking up very valuable real estate in the skull. And so it takes up some of that volume. And so the brain can compensate by, rather than compensating by losing or compressing the brain itself, it can initially respond by decreasing the volume of CSF and the volume of blood in the brain. And that way it can preserve the volume of the brain space, and therefore it doesn't increase the pressure initially. And this concept, this ability to adapt, is called the Monro-Kelly doctrine. Of course, there's a limitation on how much the brain can adapt, because the skull is ultimately a fixed space. And so you initially, with an insult, with intracranial hemorrhage, let's say in this situation, you have an increase of blood or space-occupying lesion in the brain. And so initially the pressure stays stable because it can compensate by losing some of the volume of CSF and blood. But as the CSF and blood reaches a threshold where the brain can't compensate by losing any more of it, then intracranial pressure just starts going up because of that space-occupying lesion, forcing the brain to compress more and more. All right, and I hope that makes sense here. And the dangerous part is that as the brain gets compressed, it can start leading to hypoperfusion, and the hypoperfusion can cause increase in inflammation and edema and swelling, which can then further exacerbate the condition, increasing the intracranial pressure, and it leads to this death spiral. And so that's why it's very important to intervene and break this cycle before it takes hold. And so this is where it's very important to understand this concept of cerebral perfusion pressure. And that is essentially the pressure that maintains adequate perfusion to the brain tissue, the brain parenchyma. There's a very simple equation, CPP, which is cerebral perfusion pressure. You can calculate it using this equation. It's an approximation for the CPP, and that is that map, the mean arterial pressure minus the intracranial pressure, should equal the cerebral perfusion pressure. And normal cerebral perfusion pressure should be somewhere between 50 to 90 millimeters of mercury. And of course, it's very important to keep the units straight when we're talking about pressures here. I'm using, millimeters of millimeters of mercury. The other unit would be centimeter of water. And so every 1 centimeter of water is equal to about 0.74 millimeters of mercury. So it's just very important to know what the units are if you are using local guidelines or other resources. So normal CPP can be 50 to 90, and a normal intracranial pressure would be somewhere between 5 to 15 millimeters of mercury. And we know that a normal map can be is generally between 65 to 85. And so if you were to subtract, let's say 85 from 15, you would have a pressure of 70, and that would be within right in the middle of the normal range of a cerebral perfusion pressure. Okay. And so obviously when we want to intervene, we only have 2 spots we can really intervene. So for our outcome here is cerebral perfusion pressure, we can focus on the MAP aspect of this equation, and so the mean arterial pressure. And in that case, we might allow for permissive hypertension. The brain does a wonderful job of auto-regulating, and so as soon as it senses an increase in intracranial pressure, it will increase. Typically, you'll see an increase in the mean arterial pressure, which is why a lot of times patients with intracranial hemorrhages or hematomas, they develop hypertension, and that is to preserve their cerebral perfusion pressure. And so, up to a certain point, we allow for what's called permissive hypertension, generally with systolics up to 180. But there's always a catch with higher arterial pressures. You also have an increase of risk of bleeding, and so we want to keep our blood pressures regulated, but we have a higher threshold for what our range of blood pressures are for patients with intracranial hemorrhage. And we really want to avoid hypotension, of course, because we know that if the MAP goes down with a fixed ICP or a rising ICP, then our CPP will drop. The other place we can intervene on would be intervening on the intracranial pressure itself. And that will be the focus of the next part of this talk as well. And so general principles that are good for resuscitation in general, and definitely applies especially to traumatic brain injury. And that is, maintaining oxygenation, avoiding extremes in metabolic disturbances, including CO2 and glucose, and then resuscitating as needed. So, if the patient has other injuries, stabilizing those other injuries. If there's other sources of, say, hemorrhage, making sure we stabilize the bleed in other sites, transfusing blood as needed. Whatever it is to, resuscitate the patient, you got to make sure that the patient is being resuscitated as well, and not just focusing on one isolated injury. So the first step would be, one general principle of elevated ICP would be to try to treat the underlying cause where possible. In most cases, it's difficult in traumatic brain injury because the insult happens before they arrive, and it's a very instantaneous insult trauma. So this is probably something that is less applicable to trauma. But for example, if there was a tumor that was causing a mass, you could remove the mass. If there was an infection, treating the underlying infection, correcting metabolic disorders, those would all be ways to address the underlying conditions causing increased ICP. One thing that's very important in intracranial hemorrhage and elevated ICP is positioning. And so generally the recommendation is to keep the head of the bed up to about 30 degrees is the general practice. This is actually more controversial than I expected it after looking through some of the literature. There is a trade-off that happens here when you elevate the head of the patient. And that is that you do lower the intracranial pressure, but because you increase CSF drainage and venous drainage from the head, so it helps the brain kind of be able to regulate itself, as we mentioned earlier. But if we increase the angle, the elevation of the head, we also decrease the arterial pressures that the brain sees. And so that is a trade-off we remember from our equation. The CPP is equal to MAP minus ICP. And so if our MAP that the brain is actually seeing goes down slightly, then there's a risk for not perfusing it as well. And so, generally the teaching is everybody agrees that the head of the bed should be kept under 45 degrees. You don't want to sit the patient upright. Most people keep the head of the bed about 30 degrees. And then the other thing that's very important is to keep the jugular veins open where possible. And in traumatic patients, actually, this is often something that gets missed or something that we don't really focus on. A C-collar often is something that we do to stabilize the cervical spine in traumatic injuries, especially if we're unsure if or there's a true neck fracture, an unstable neck fracture. And so the collar itself many times can obstruct the jugular veins and can decrease venous drainage. And so that's something to keep in mind. If it's needed, it is needed, but it's just something to keep in mind, especially if you have a very low suspicion for cervical spine injuries. Keeping the head in a neutral position rather than tilted to either side is also very important. And avoiding internal jugular central lines would be also ideal in the situations. You can go for, if you do need central line access, in these situations, it might be better to look for alternative sites such as a subclavian or femoral. If it is needed again, do what you have to do. But that's something you can keep in mind in order to optimize. The next section for strategy would be ventilation. And this is something that, we all learn in med school, but it's something that's very important in this context. And that is how CO2 can affect the vasoconstriction and vasodilation in the brain. So the goal is actually, this is sometimes a source of misconceptions, but the goal is actually to keep normal capnia in a patient, even in a patient with intracranial hemorrhage, with a CO2 level of about 35 to 40 millimeters of mercury, if you have access to venous blood gases. And you can correlate that with end tidal monitoring as well. The idea is to keep normal capnia. That should be the goal. If, however, you do have a case with refractory increased intracranial pressures, or a patient is being bridged to a more definitive treatment, for example, they are going to have their hematoma evacuated with neurosurgical intervention. In that case, you can consider hyperventilation in a patient who's intubated and has a bridge to definitive care. By hyperventilating, you are lowering the CO2, which can also help with decreasing the ICP. The thing that's very important to note is that the brain, the body in general, is very good at adapting to new situations. And so as you lower the CO2, the body will adapt to this lower level of CO2. And so this is a very temporizing measure. It's very temporary. And once you stop hyperventilating the patient, there's a risk for a rebound effect. And if you do maintain low CO2 levels for a prolonged period of time, there's also a risk for cerebral hypoperfusion because of ischemic injury as well. And so this is not something that you want to be doing for the long term. All right, and the next thing that we consider is temperature management. Our goal here is normothermia. There is, oftentimes because of we kind of pull things from other areas of medicine, we think that they apply generally, to all other areas. And so, for example, targeted temperature management with hypothermia is something that is indicated in resuscitations, cardiac arrest, for example. But in this situation, typically the recommendation is normothermia. And people who were treated with prophylactic hypothermia in some studies did not show improved outcomes. And with hypothermia, there's also a risk for inducing bradycardia or hypotension, and that would impair brain perfusion. And we know that that's something that's incredibly important from our very basic equation, that CPP equals MAP minus ICP. And so by lowering the MAP, if you induce bradycardia or hypotension, then that actually increases the risk for hypoperfusion. And so the other risk is if the patient becomes hyperthermic. That's really the danger here. That can increase metabolic demand, especially within the brain. And so that puts the patient at further risk for hypoperfusion and metabolic encephalopathy. And so the goal here is to just ensure that the patient does not become febrile. Typically speaking, something such as acetaminophen is adequate to maintain normal temperatures, but sometimes you need to do more active cooling in order to maintain normal temperatures in patients. And so antipyretics are generally the indication here. Osmotherapy is a very broad topic, and this is something that we could spend a lot of time on, and we'll try to make sure it fits within our time limits here. But the goal here with osmotherapy is using taking advantage of the osmotic gradient between the across the blood-brain barrier. And so again, if we go back to our basic chemistry here with osmosis, fluid will go from an area of low concentration to an area of high concentration when there's a semi-permeable membrane. And in this situation, the blood-brain barrier acts as a semi-permeable membrane. And so with our goal is that if we want to draw fluid away from the brain, we can use osmotic therapies to increase the osmolality of blood to decrease the volume of fluid in the brain. So there's a lot of different approaches to this, and we'll kind of talk through some of them. One of these agents is hypertonic bicarb, sodium bicarb. It has approximately the same tonicity as 6% saline. And so it's about twice as potent as a 3% saline, which is already a hypertonic agent in itself. And so typically the recommendation is 2 to 3 ampules of hypertonic bicarb, which amounts to about 100 to 150 mLs, can be used as emergent therapy for elevated ICPs. The advantage here is that it's generally pretty accessible and can be accessed immediately, and it can be administered relatively quickly and bolused rather than done as a continuous infusion. But of course, it would be contraindicated in patients with pre-existing metabolic alkalosis, which would just be made worse by introducing bicarb. The next would be a 3% saline infusion. And this is something that can be done either as a bolus of 250 mLs is generally the recommendation. It can also be done as a continuous infusion. And a lot of studies have shown that 3% saline is actually safe to administer through a peripheral line. You could also administer it through a central line and through an intraosseous line. But again, remember that if you are placing a central line only to administer hypertonics, the recommendation would to be avoid to use the internal jugular. And so this is something you could use a peripheral line for and might save you placing a central line. There's a higher concentration, 23.4% saline, and this can also be given as a bolus, generally given as a 30 ml bolus over 10 minutes. And it's very important that it is administered over those 10 minutes. You know, it's a very small volume, it's only 30 cc's, but faster administration has been shown to have higher risks of developing heart failure due to volume overload, just because of the extreme tonicity of 23% saline. Generally, it is ideal to administer this through a central line, but you could also administer it through intraosseous access if the central line is not available. There was one study actually that showed, it was a large series that followed 57 patients who had 23.4% saline administered peripherally through a peripheral IV, and none of them faced adverse events. Of course, it's one study that I was able to find, and probably more research is needed to have a definitive conclusion of whether or not it could be administered peripherally. But if it is an emergent situation and you don't have central access, that is something that you could consider. The next agent that you could consider is hypertonic sodium acetate. And this is something that actually is very helpful because we know with saline, normal saline 3% or 23%, they all have a risk of developing a non-anion gap metabolic acidosis or a hyperchloremic acidosis. Essentially, the chloride ions in the NaCl from the saline displaces a lot of the bicarb in order to maintain an ionic balance between the negatively charged bicarb and the negatively charged chloride ions. And so this can lead to hyperchloremic metabolic acidosis as your body displaces that bicarb. And so one strategy you can use is to use hypertonic sodium acetate, which does not carry that same risk in order to reduce the risk of developing metabolic acidosis. There's different strategies. Some people use a balanced mix of hypertonic saline and hypertonic sodium acetate if they need more resuscitation or continuous infusion. And some people use this as a backup to switch to if a hyperchloremic acidosis develops. And the last agent is Manitol. Manitol is something that's widely used, and it's something that we often associate with intracranial hemorrhage and elevated ICP, but it also has a lot of downsides, especially when compared to these other therapies. And a lot of studies are showing that, well, not a lot of studies, but there are some studies that show worse outcomes with use of Manitol when compared to other hypertonic agents that we discussed. Some of the downsides include that Manitol is potentially nephrotoxic. and can induce diuresis as well. It is a diuretic, and that can eventually lead to volume depletion, which can lead to lower MAPs and brain hypoperfusion. And the other risk that comes with mannitol is that there could be a rebound elevation in ICP, because eventually mannitol does cross the blood-brain barrier. There is a delay, but eventually the mannitol can eventually cross the blood-brain barrier and can eventually lead to an increased ICP. There was a meta-analysis that was done, and we could provide this in the resources later, but that showed that mannitol was less effective than hypertonic saline and had higher rates of kidney injury. So important things to keep in mind. It really depends on what your institution recommends and what you have available to you. But these are different things you can have in your toolkit.
Also,
and when
to add on to that,
yeah, please.
to add on to that, Sami, thank you for the presentation so far. It's quite wonderful and comprehensive. The effect of mannitol also depreciates after 72 hours, so you're not able to get beneficial effects from prolonged use of mannitol. So it's advised that once you use, in our setup, we have mannitol and 3% hypertonic saline. So once we do our 72 hours of mannitol, then we now switch to the 3% hypertonic saline, which is more beneficial than the mannitol in causing an osmotic effect. Then that's what you want. I'm seeing there's a question on the chat. Somebody had asked, when does a lucid interval happen in TBI? Most lucid intervals happen secondary to an epidural hematoma. With an epidural hematoma, what is important to note is that's usually an arterial bleed. So arterial bleeds usually, of course, the artery will bleed faster. It will accumulate in the brain tissue quite faster. And we know that for an effect for the effect to be felt in terms of getting the loss of consciousness, the brain only needs 100 or 150 mLs extra for it to be compressible. And that's when you end up now having that pressure effect that causes the lucid interval. I'd seen that in the question log, and I thought I needed to answer that. Can proceed.
I appreciate that. That's wonderful. And a very good answer. And so there's some debate between using continuous versus bolus of hypertonics. I'd say probably most commonly people generally go with continuous infusions, but there have been some more recent studies that show that bolus can not only be a safe method for introducing osmotic therapy, but it can actually be safer because it avoids some of the downstream consequences of a continuous infusion or the higher rates of monitoring that a continuous infusion requires. And yeah, I think that's all I'll say on that. So if you do pursue a continuous infusion method, especially, it's very important to make sure that you monitor for safety. And so we really want to avoid hypernatremia as well. So, generally speaking, we want to avoid a sodium level of greater than 155 MEQs per liter. We want to avoid also hyperchloremia. We discussed already the risk of developing hyperchloremic acidosis. And so you want to avoid the chloride rising above 115 MEQs per liter. And we talked about how if we do develop hyperchloremic acidosis, we could switch from hypertonic saline to hypertonic bicarb or sodium acetate. And that's part of that. We want to avoid increasing the sodium for more than 6 to 8 MEQs per day. Just like when we're treating hyponatremia, there's a risk for osmotic demyelination syndrome. And so that's something you want to monitor very closely. And this is also probably a big reason why bolus therapy can have an advantage over continuous therapy, because there's a lower risk of overcorrecting within a 24-hour period and doesn't need as much monitoring. And of course, we want to avoid volume overload. With these hypertonic solutions, a lot of the fluid's being retained in a way that normal fluid isn't. And so we just want to be very careful with how much fluid we're administering. And so The next part would be surgical management. This is something that can be considered for refractory cases with elevated ICPs. They may need decompressive craniectomies, which is where you remove part of the skull in order to open the dura and allow for the brain to decompress and swell. And that kind of removes the restriction that we saw with the Monro-Kelly doctrine. The skull no longer becomes a fixed space. We open that space up. And it really depends on, obviously, the recommendations from your neurosurgeons and neurosurgical colleagues. And it depends on the underlying pathology. The evidence is best for younger patients who have large strokes, especially those involving the middle cerebral artery. And so this is what, decompressive hemicraniectomy might look like. We talked about how it could be considered for refractory elevated elevations in ICP. And, we included in the resources, here's there we go. Here's the slide with the link if you want to copy this link over here or use the QR code. But there's a wonderful website that has guidelines that can help with decision-making for surgical management of patients with intracranial hemorrhage. There's a lot of details that go over every kind of bleed and what would be indicated in those kinds of bleed.
There's somebody who's asking in the chat, what is NAGMA? Could you elaborate on what that is?
Yeah, of course. I'll go back here. The NAGMA is the non-anion gap metabolic acidosis. And in this situation, it can also be called a hyperchloremic acidosis. And it's essentially because there's no anion gap because the acidosis is caused by a relative decrease in the bicarbonate, which is a measured anion.
Just to also add on to the management, when you're managing this kind of patients, you're trying to look at maneuvers that will reduce the amount of fluid or the amount of blood that is getting into the brain so that you do not have excessive fluid leading to cerebral edema. So what you should aim is having situations whereby you're causing a vasoconstriction instead of a vasodilation. So that's why we end up with saying that you need your CO2 levels normal or reduced, because what happens with increased CO2, you tend to have vasodilatation, meaning that you have increased fluid into the brain tissue. And all these maneuvers, the acidotic state would also lead to a situation whereby you're you're dilated. So this increases the amount of fluid that gets into the brain, and hence you now worsen the situation. So you're always aiming at trying to make sure that you're reducing the amount of blood or fluid that is in the brain, so that the brain can be able to recover and reduce the ICP, the intracranial pressure. Can proceed.
Yeah, thank you for the explanation there. And this, uses the exact same principle. This is another consideration, is an external ventricular drain. And the benefit here would be that it can drain, but then it can also be used for continuous monitoring as well for pressure. We'll go on to the next thing. So, a question that often arises is the roles of steroids for traumatic brain injuries. And so there's a wonderful study that was done here, Crash 1, back in 2004, which showed that for patients with severe TBI, so in that 3 to 8 GCS score range, high-dose methylprednisolone was associated with increased mortality, and so is contraindicated. And so generally speaking, the recommendation is against steroids for TBI specifically. This is not to be confused with other reasons that a patient could have increased ICP or other pathologies, for example, certain kinds of meningitis or vasogenic edema from a brain mass. Those are other situations. And so this is not a general principle, but specific for severe TBI. Steroids have not been shown to be effective and actually increase all-cause mortality at 30 days.
Sammy, was dexamethasone studied in this trial? There are a lot of questions within the group chats, specifically questioning dexamethasone.
This study specifically looked at methylprednisolone, I believe. I don't know if there's been other studies on other steroids. The other question would be for tranexamic acid, or TXA. And here's a wonderful study from 2023, so a little bit more recent. And it showed that for patients with moderate or severe TBI, those with extraaxial hemorrhage alone who were treated with 2 grams of TXA within 2 hours of injury had reduced mortality and improved neurologic outcomes compared to those who had combined both extraaxial and intraaxial hemorrhage. And so for the recommendation from this study was that there could be a potential benefit from using TXA for patients with moderate or severe TBI with intracranial hemorrhage. And this was done at the University of Chicago. And I'll hand it back to Dr. Njoki.
So we'll look at a summarized approach to everything that has been discussed. This is an escalating 3-tier approach that has been adopted for the treatment of ICH. So, sorry, just a minute. So the next slide is a bit more detailed. So there are 3 tiers, tier 1, tier 2, tier 3. So tier 1 is basically what you do when the patient presents to the ICU setting. So you maintain your CPP between 60 to 70 as discussed. You might want to use analgesia to lower your ICP and use sedation as well to lower your ICP. You maintain your PSU2 of 4.7 to 5.1. Then there's been the discussion of using hypertonic saline by intermittent boluses or Manitol. You can also relieve ICP by doing CSF drainage through the EVD. And then also there's the use of anti-seizure prophylaxis, usually for 1 week only, unless there's any indication to continue with the medication. Then you also consider EEG monitoring if it's available in your facility. So basically, when you're using this tier approach, you use the lowest tier treatment, that's meaning tier 1, but tier 2. And there's no specific order into using any treatment management in each tiers. So it doesn't mean you have to do analgesia first before sedation. You can do them both concurrently. And then it's not necessary to use all tiers in all management aspects in one tier before you move to the next tier. So basically, before you move to the next tier, you have to re-examine your patient. If there's still signs of increased ICH, you can consider repeating a CT scan to reevaluate whether there is an expanding intracranial pathology or a missed pathology. Then at this point, if you repeat a CT scan, you can consider whether now if the patient needs any surgical intervention. Also consider other extracranial causes of ICP elevation. Maybe you didn't elevate your bed. Then also review your basic physiological parameters. So your ABGs, your CPP, your MAPs, your ICP. And also, it's also important to consult with your seniors before you move to the second tier. So in tier 2, you go to a bit more of extreme measures. You do the mild hypocapnia. So your PCO2 will decrease a bit to 4.3 to 4.6. You can consider neuromuscular paralysis if your sedation is not adequate. You can perform a MAP challenge. This one is usually left to experienced physicians who've done it before. So this one can determine whether you need to start your vasopressors or inotropes to increase your MAPs. Then there's the tier 3 management. where you put the patient on thiopental coma to help titrate the ICP if it's not well controlled. You can consider doing a secondary decompressive craniotomy. And then there's also the use of mild hypothermia. So as you escalate to each tier, it's also associated with more complications. So that's why you should consult first, and then reevaluate the patient if they need an escalation.
Nancy, just to interrupt a bit, there's someone who's asking what's the effect? Why should we maintain normal levels of sodium, normal sodium levels? Maybe you can elaborate on that.
I think he's touched on it, on why your sodium shouldn't be more than 155. Maybe Sami can discuss that.
Okay, I can help. You see, when you have increased sodium levels, you're in a hyperosmolar state. So what happens is now that you're going to draw water from the tissues, and when you draw the water from the tissues, the cells will shrink, and eventually you'll have now neuronal damage, and you also have now the cells shrinking. And what happens at the end of it all, you'll also have inflammation. So this, you do not, at this state, in this kind of patients, you do not want to have high sodium levels, because it will cause like a sort of an osmotic effect, which will eventually now damage the cells. And that's why we end up having patients getting loss of consciousness. You'll have a patient presenting with seizures, and you're wondering why are we getting these seizures, and you thought you've probably sorted out maybe the epidural hematoma or the subdural hematoma surgically. So when you go back and you find out that your electrolytes are not well corrected and you have high sodium levels, this is one of the contributing factors that could lead to the seizures and the loss of consciousness.
Thank you for that. So we can move on to rehabilitation. I think this is an aspect we often forget about. So there is the rehabilitation, which is defined as, it's a set of interventions that you do to the patient to optimize their functioning and also reduce their disability and also facilitate their interaction with the environment. So there are three main aspects you look at when you are doing your rehabilitation. There's the cognitive aspect, the physical aspect, and emotional aspect as well. So it's been shown that rehabilitation should begin from your point of contact with the patient, not to wait until they are discharged. So early rehabilitation will help the patient experience shorter acute phases and shorter hospital stays, and even better performance once they're discharged from the hospital. So part of the early rehabilitation involves like serial assessment of their consciousness to see if there's any other additional thing you can do to help them improve. There's the posture and tone management you can do. It's mostly done by a physiotherapist, where if they need splints, stretching regimes, medications to just help with their posture and tone, intervene. Then it's also proper to advise the family regarding, it's also proper to start advising maybe your nurses or critical care team on early mobilization as well. And also advice regarding sleep problems or what you can do to help facilitate better sleep in those patients. You can help in pain management, managing agitation, dysautonomia, bladder and bowel function as well. Then there's also the serial assessment of amnesia, the post-traumatic amnesia as well, and intervening when need be. You can assess your patients for their ability to communicate and swallow. I think this mostly falls in your mild TBI patients, mild and moderate. Then provide any assistive technology if it's available. You can help your patients with tracheostomy care and also the process of weaning off tracheostomy as well. You can take care of their nutrition, which is very important in these patients, and also plan for long-term nutrition care. Also, since they'll be immobilized for a long time, it's important to take care of their skin, take care of skin breakdown, because this is where they get the bed sores and then the sepsis cycle starts. And then it's also good to assess if they have any ongoing rehabilitation needs that they might need to be transferred to a long-term rehabilitation facility. And these are discussions you can have with their family members. So the other thing is also providing family support and also updating them on the prognosis of the patient, which is all part of the rehabilitation process. So to end, we can all prevent traumatic brain injury among ourselves, among our patients, by some of these basic things, like wearing a helmet when you're riding a motorcycle or riding a bike, or even in children when they're riding their bikes or skating. You buckle up when you're in a car. Don't do drugs while you're driving or using heavy machinery. And then you also assist our elderly population to prevent falls. And then for children, we also ensure they live and play in safe areas, of course, with guardians as well.
Thank you so much. Going back to just a few clarifying questions from the chat. Which do you all prefer, or what would be your go-to Manitol versus hypertonic saline?
Okay.
I'm just trying to find how
I
to
think
unmute.
sorry. Oh, sorry, you can go ahead,
Go for
Sami.
it. No, you can go for it.
In my setup, I'm talking about my experience. I don't know about now the high-income countries. For us, it all depends on, one, the availability of the drug. On us, in our setup, hypertonic saline is quite expensive. So we usually start with our Manitol, and then should we get the hypertonic saline, we then administer the hypertonic saline. But the preferred standard would you just start your hypertonic saline because of all the side effects that Manitol has, and the hypertonic saline is more beneficial in terms of the outcome that you intend to have.
I agree with you, Rachel, and I think it definitely depends on what's available, even in high-income countries. Sometimes we only have Manitol, and sometimes we have Manitol and hypertonic saline. I think in general, we would probably choose hypertonic saline initially if it's available, but it to my knowledge has not been shown to change dramatically the mortality rates in the acute management of traumatic brain injury.
We also had a few questions on antibiotics for ventriculitis prevention, as well as prophylaxis and penetrating TBI. I wondered if either of you or anybody else had any specific thoughts for what they preferably use or have available.
So,
Yeah, go ahead.
okay, all right. For antibiotics, yes, especially for penetrating head injury patients, it's advisable to put them on antibiotic therapy because one, it could have been a patient was by the roadside and was hit, so there's a risk of getting an infection. So we usually advise here that once the patient comes to the facility, we usually start them on cephalosporins, either ceftriaxone, as we wait as well for blood cultures, which you'll have taken before you start your administration of antibiotics.
Yeah, just to add to that, so certainly if there's a penetrating head injury, additionally, patients with EVDs or external ventricular devices, we tend to keep the antibiotics prophylactically on for as long as the EVD is in place. They don't stay in too long. So as soon as the EVD comes out, if there's no evidence of infection, we'll stop the EVD. I'm sorry, the antibiotics. Additionally, just this month, there was a study that came out for patients with severe traumatic brain injury. Those patients are usually intubated and placed on mechanical ventilation, and they are at very high risk of ventilator-associated pneumonia. So it's now recommended that you give a one-time dose of 2 grams of ceftriaxone at intubation. That article just came out this month. So there might be another indication to give ceftriaxone on that first day. Otherwise, the use of antibiotics other than prophylactically for the EVD really should depend on the patient's risk of infection. So are they having a risk of ventilator-associated pneumonia? Are they having a skin or soft tissue infection from their trauma? Or are they having complications of sepsis and septic shock? So the antibiotics would be specific to those things. So antibiotics for EVDs, antibiotics in severe traumatic brain injury, one time for prophylaxis against ventilator-associated pneumonia. Otherwise, it's dependent upon the situation of that patient. Is now a good time for me to review the Learning Resource Center and how people can find the slides?
I think that's a great idea.
Okay, do you mind if I share my screen? Okay, so the Learning Resource Center, the link to this has been put in the chat several times. And we can do that again just now, but this is our free online school. You do have to create an account, but again, it's completely free. When you go to the school, you can find the 2024 Critical Care Bootcamp course card here. Once you're in the course card and you scroll down, you can see that Module 1 yesterday was on stroke. And then today is on traumatic injury in the brain. It may take 1 or 2 days for us to be able to upload the webinar recording. We also are creating a library of resources for you all that will be available. And then also many of the questions we realized were not answered during the session. So we're creating a document for the most frequently asked questions. So you can review those there as well. So from yesterday's.
It seems some people are unable to see your screen.
Oh, really?
Sorry to interrupt.
Oh, thank you. Let me go back then. Can you see my screen now?
No.
I think some you have to bring down your slides.
We're getting a lot of yeses, so good.
Okay, yeah, so Sammy's, we can, I think because we can share simultaneously. Okay, so Sammy, you've stopped sharing.
Correct,
So
yeah.
I will go ahead and start sharing again. This is the Learning Resource Center. When you scroll down, you can see the course card here, Critical Care Bootcamp. When you scroll down, you should be able to see yesterday's session on stroke. You can see that we have slides and a library of resources. And then the webinar recording is also located there. You can click on any of those. And soon we will have a document on frequently asked questions. If we click on the slides for stroke, you can see that as you click on the stroke slides, you can see the slides there. But notice in this upper right-hand corner, there is an icon that has a paper clip. When you click on that paper clip, you will see the PowerPoint slides themselves here, and this is what you click to download the slides. Any of the resources that we have shared that we think will be helpful to manage patients with stroke or traumatic brain injury will be in the library of resources. So for example, from yesterday, for stroke, we have a resource library. You can change the slides here at the bottom. This is how to detect stroke, time critical management of stroke. These are management algorithms that you can use. We've talked about ischemic stroke. Here's some guidelines. Here's criteria for when you would give TPA or not. Mechanical thrombectomy criteria. Blood pressure management if TPA is given. Blood pressure management if TPA was not given. Long-term management of stroke. Prevention of further stroke. And then we talk about hemorrhagic stroke. So we're giving you guidelines, we're giving you aids that you can use at the bedside, and we're giving you algorithms for management of these conditions. So here is traumatic brain injury slides. We have the slides up already, but notice that there's no icon to download these slides. That's because we still need to make some adjustments to the slides to answer some of your questions. So just as soon as we have the slides ready, they will be posted here for you to download. Similarly, we have a library of resources for traumatic brain injury. These are also not available yet for download because we're still adding really good resources to make sure that we answer all of your questions. But we have prevention, pediatrics, adults. So we're going to continue to add resources here in order for you to have the good tools that you can use at the bedside to care for these patients. Additionally, you should receive an email from the webinar that has a link to the LRC so that you can have that link to access those materials. And it should have some other links as well. I'm going to go ahead and launch that poll again that we had at the beginning and let you answer the questions again and see if our answers have changed. So the first question, when treating traumatic brain injury, what are the 3 H's is the first question. Second is true or false, hyperventilation less than 35 causes vasoconstriction and decreased perfusion. True or false, EMS providers can help prevent secondary brain injury in the pre-hospital setting. Number 4, patients with traumatic brain injury should have an oxygen saturation above what %? I put the link to the LRC in the chat again. Additionally, if you would like to join our WhatsApp group, I'm putting that link in the chat box right now. Okay, I'm going to end that poll. Next, I'm going to launch the survey. So let's see. Sammy, what do you think about the answers on question number 1? You're on mute. Sorry.
I don't see the questions or the, well, do you have the results from it? Oh, there we go. Yeah, it looks like people got it right. And I think that's also a higher rate than we had at the beginning. But the main difference here was the hypotension, which we really focused on in this lecture. And so you guys did a great job.
You can review all
Should we
the
do all of
questions,
this?
Ami. Yeah.
Okay. I don't know if you wanted to do one of them. Yeah, true or false, hyperventilation can cause vasoconstriction, which can cause decreased perfusion. Yes, that's one of the risks for it. Even though it is a strategy to try to decrease the ICP, we talked about how it can cause vasoconstriction and hypoperfusion. So something to keep an eye out for. True or false, EMS providers can take actions to help prevent secondary brain injury. And that is definitely true, and looks like almost everybody was able to get that one correct. Great job with that. For this one, it looks like there's a little bit more of a divide. I know, Nancy, that you had put these questions together. I don't know if you have thoughts on helping differentiate between these two. The answer is 90%. This is the one that I think is probably important to focus on a little bit more.
So I saw actually two different guidelines, depends on the guidelines you look at, but majority recommend at least above 90%.
95.
Yeah, I think the UK guideline is one that is strict on 95%, but the rest was 90%. So I think we can go with both.
Either way.
Great. I want to thank again today's speakers for this really excellent discussion on traumatic brain injury. Remind all of the participants that resources will be available in the next day or two on the Learning Resource Center. If you participated for 45 minutes and you fill out this poll that I'm launching now, then you will receive a certificate at the email address that you provide. So make sure you fill out this poll now, and I'll leave the webinar open for some time in order to allow you to complete that poll. Thank you to Sammy Matar, Danielle Devakis, Eugene, Rachel, and Bansi and Joke for such a wonderful presentation today. We appreciate it.
Thank you so much, everyone. Thank you for your participation.
Yeah, this was a pleasure. Thank you so much.
Thank you for your time.